Hello, everyone. Thank you very much for coming to this post-prandial session. I would like to start out by letting you know, in my role as medical director of AlphaNet, that AlphaNet has the entire array of skinny little reference guides, which are educational pieces pulled from our big fat reference guide, and we have them outside in 6 different languages, in addition to English, Italian, Spanish, German, Portuguese, and French, if you're interested. I'm going to talk this afternoon very briefly about alpha-1 lung disease and specifically about current and future therapies. In a way, it's an introductory talk to the speakers that will follow me. If we talk first about current therapies for lung disease, the therapies for lung and for liver disease mimic the usual therapies for COPD and cirrhosis in the adult. Of note, it's important to realize that most of these therapies were never tested in patients with alpha-1 lung and liver disease. We just assume that studies done in COPD and studies done in liver disease are applicable to alpha-1 antitrypsin deficiency. They are likely to be applicable. Certainly our patients seem to respond well to them, but that's an assumption that we make, and maybe we would find if alpha-1 patients were included in more studies of COPD and liver disease, that there are certain medications that would be preferable one over another in alpha-1 that we don't learn about from looking at just studies on COPD patients without alpha-1. Without going into any detail in this, I'll simply mention that the final common therapy that both lung and liver disease have in alpha-1 is organ transplantation. And so that's all I will mention of organ transplantation in this talk. What are these usual therapies for lung disease? They are bronchodilators of various mechanisms, beta agonist inhalers, beta agonist pills, anticholinergics, things that dilate and open up the bronchial tubes. They are anti-inflammatories. Anti-inflammatories that we use include leukotriene inhibitors, but most commonly glucocorticosteroids, usually by inhalation, steroids as we call them. And of course, there are various combinations and permutations, especially in inhaled medications, of these inhalers, of these different classes of medications, and a growing number of combination medications that include 2 and eventually 3 of these medications all at one time. And the other thing that's been changing in current therapy is the introduction of longer and longer acting inhalers, so that now really the current standard is to have inhalers that you only need to take once a day if you have the health care coverage or the pocket money that will allow you to afford those inhalers. There's an old/new class of medications that are used called phosphodiesterase inhibitors. The old version of that, theophylline and aminophylline, and the new iteration of that, although not really being used in the same way, as drug like Dalaresp. I'm not sure if it has different names in various European countries, that are used in frequent exacerbators to cut down on the frequency of that exacerbation. And then, of course, exacerbations of lung disease in alpha-1 are currently treated in the standard way that COPD exacerbations are treated, with antibiotics if it seems to be infectious, with steroids, with chronic antibiotic use in certain situations. That is the main armamentarium that we have against lung disease in alpha-1 antitrypsin deficiency. But of course, there's also therapy that's specific to alpha-1 antitrypsin deficiency. And for lung disease, of course, that's augmentation therapy or replacement therapy. It's administering intravenously alpha-1 antitrypsin protein derived from the plasma of human donors, and as it's currently administered at a particular dose per weight, usually on a weekly basis. For the liver disease, there is currently no available specific therapy that's geared towards alpha-1 antitrypsin deficiency. So what can we expect to see in the future? First of all, I need to mention that although you've heard about future therapies for liver disease, it's hard to talk about lung disease without talking about future therapies for liver disease, because any disease that improves liver function in alpha-1 is going to improve lungs and the risk of lung disease. But if we concentrate on lung future therapies first, the major early thrust has been on alternate augmentation therapy approaches. And so those alternate approaches include giving the drug that's given intravenously in augmentation therapy by inhalation. And the questions surrounding that are whether the inhaled drug gets to where it needs to be, as well as giving it by intravenous administration. And I think that while the final answer on that is still out, there's certainly enticing indications, enticing evidence that at least some of the effects of augmentation therapy can be achieved by taking the drug by inhalation. And clearly more work needs to be done in this area. There have been starts and stops and successes and mostly failures in the recombinant therapy arena. So recombinant means that you take the human gene for alpha-1 antitrypsin protein and you put it into some type of system that makes it in the lab or factory, makes that human protein. And that can be something like putting the human gene into a bacteria or many, many, many bacteria and having the bacteria make the protein. It can be putting it into cells that are from mammals, mammalian cells that are grown in culture. Unfortunately, alpha-1 antitrypsin is a molecule that has very specific sugars stuck on the outside of the protein. And unless you make that alpha-1 antitrypsin protein in probably a human-derived cell, it's going to be very difficult to get an alpha-1 antitrypsin protein that looks exactly like the cells exactly like the protein that our liver makes. But fortunately now there are types of production facilities that are able to make human proteins in cultures of human cells. And so we may see work moving forward in recombinant proteins, or recombinant proteins may in fact be able to be given by inhalation, where how long it lasts in your body isn't as important, because you can take an inhalation 1, 2, 3 times a day. Even if the protein is cleared rapidly, it still does the work that we need it to do. And finally, there are, in this area, a number of chemicals that have been designed that are able to block the enzyme neutrophil elastase, which is the enzyme that in alpha-1 antitrypsin deficiency does most of the damage to the lung, leading to emphysema. And so the possibility exists that you could have a pill, much like your statins or your antihypertensive medications, that blocks the activity of the enzyme that destroys the lung in alpha-1 antitrypsin deficiency. One of the things that's been very clear over the recent years is that alpha-1 antitrypsin protein is more than just an inhibitor of human neutrophil elastase. And so it may be that a simple drug that blocks neutrophil elastase may not be sufficient to do everything that alpha-1 antitrypsin does. This is ongoing work that we'll need to evaluate in the future. I'm sure that more talk will be made regarding gene therapy in alpha-1, but I'll put my 2 cents in. Right now, there are human studies going on looking at gene therapy. Gene therapy's first approach has been to inject the normal human gene using a virus to infect the cells and turn them into alpha-1 antitrypsin factories. And the target cells have been muscle cells. And so the two studies that have been done in humans so far have injected the human alpha-1 antitrypsin gene into muscles. In the latest study, the highest dose group got 100 intramuscular injections at a single sitting. And the good news of those studies is that a single treatment like that has led to the production of normal human alpha-1 antitrypsin in deficient patients for years after the treatment. The bad news of those studies is that even with 100 IM injections, the levels of normal human alpha-1 are not sufficient to be protective of lung. The other downside to this approach is it would not be expected to help the liver disease in any way. It would be the equivalent, if you could get appropriate levels, of having a continuous infusion of augmentation therapy, which would be a good thing if it takes only one treatment. And there are new studies that are in the plans to find ways to get many more cells making alpha-1 to raise those levels up. In addition, if gene therapy is directed to the liver, that could potentially treat both the liver and the lung disease, and I'm sure you'll hear more about that in subsequent talks. Then there are reparative therapies, retinoids like all trans-retinoic acids, that in laboratory animals are able to trick the lungs, if you will, into growing new alveoli or air sacs, which could be a recovery or a treatment for emphysema. If you grew new air sacs after air sacs have been destroyed, the emphysema would be reduced. So far, those studies have not yielded very promising results in humans. And then there's stem cell therapy, which Jan Stock will talk about directly. But I want to also just mention the liver disease future therapies. You may have already heard about these. In addition to the gene therapy directed at the liver, there are gene silencing techniques designed to turn off all production of alpha-1, which would help the liver, but would leave the lung unprotected. And so therefore, that would always have to be accompanied by some form of augmentation therapy, whether it's another gene therapy or something else. It makes for a complex situation, but one that actually aims to be a curative therapy. There are a number of drugs that are being developed aimed at either preventing the aggregation and polymerization of the protein in the liver, or depolymerizing, breaking up alpha-1 that's already aggregated in the liver. And then there's stem cell gene correction, which I'll talk about briefly in the last couple of slides. I want to show you you don't have to read this diagram, but I put this up because this is the diagram that I submitted to the New England Journal when they asked me to summarize some of the results of these gene therapy, these stem cell gene repair therapies, because I wanted to show you what the New England Journal of Medicine changed this diagram into. They changed it into this diagram with the hairy, scary, naked guy in it. And basically, what this study did was take skin cells from alpha-1 patients, turn them into stem cells, repair the alpha-1 gene in the stem cells, convert the stem cells to liver cells, and with the aim of giving those cells back to the donor's liver so that it could repopulate the liver of the alpha-1 antitrypsin deficient patient with liver cells that had the normal alpha-1 gene in it. And these sets of experiments that were done in a collaboration across the Atlantic in the US and Europe was successful in every one of those steps except the last step of giving it back to the patient. The reason it wasn't successful in the last step is only because the investigators chose wisely not to give this back to a human until problems with the generation of cancer were solved with stem cells. Because as stem cells grow in culture, they tend to accumulate mutations, some of which can lead to cancer. And so they injected these cells into mice and showed that these cells could populate the liver of these mice without causing cancer and lead to the generation of human alpha-1 antitrypsin protein in these mice. So this is a therapy for the future, but every one of the early steps has been created. And so I'd like to end with a slide that is my own personal view of the cure for alpha-1. I think there are many routes to a cure for alpha-1 antitrypsin deficiency. To cure the lung disease, we have to look at prevention or transplantation under the current situation that we are in. But we hope that in the future, there could be stem cell or retinoid-like repair processes that could reverse the changes of emphysema. If you cure the liver disease, that can provide an overall cure for alpha-1, whether that's by gene silencing plus augmentation therapy, some kind of polymerization, prevention, or correction, liver repopulation with gene-corrected cells, liver-directed gene therapy. We have a whole array of potential projects, all of them being worked on, that have the potential to lead to a cure for alpha-1 antitrypsin deficiency. And with that, I will leave you.